It's the first Monday in October, and we're officially into the depths of autumn. Don't let that sun fool you. It was raining cats and dogs and cows and pigs and who knows what else all weekend long. And then the Monday that you need to come to work, it's sunny. This is Pospo and BRAINCAST, your weekly dose of brain science. Last week, we delved deep into the science of emotions with Dr. Gemma Modinos, a powerful advocate for all young scientists across Europe. We talked about brain networks, about neurotransmitters, and how these may impact on the emotional dysregulation we see in people suffering from psychosis. This week, we close our eyes and delve into the magical world of sleep. Okay, I'll keep my eyes open, otherwise it will be a bit weird. So with me, a consultant neurologist and the clinical lead for the Sleep Disorder Center at Guy's Hospital, one of Europe's largest sleep units, a reader in neurology, a principal investigator and collaborator in several multi-center studies. You may have heard him on BBC Radio or seen him on Channel 4, but let's admit it, his lifelong ambition was to come here at Monster Learning's BRAINCAST. Dr. Guy Leschziner, welcome.
This is much better than Radio 4.
Guy, thank you for joining me today. I don't know why.
It's a pleasure.
When I invited you to join me here on BRAINCAST, the thing that came to my mind was, I don't know, it sounds really weird. The first two people on Earth, walking into desert, and then one of them falls asleep for the first time. It must have been shocking witnessing that. Imagine the horror they felt. I mean, what the hell is happening? And the question is equally weird. When was the first report of someone falling asleep?
Well, I think that it depends how you define sleep. I mean, we know that there are written reports from, ancient Chinese texts from, 400-500 BC of discussion surrounding sleep, surrounding insomnia, and even some aspects of sleep medicine, what can be interpreted as sleep disorders now. Aristotle, of course, wrote about sleep at around 300 to 400 BC. Somebody I'm sure is dear to your heart. But actually, the oldest text that I'm aware of is the Egyptian Dream Book, which actually you can go and see for yourself in the British Museum. So if you ask the British Museum to look at it, they will pull it out from their stores. You'll get ushered into the ancient Egypt and South Sudan reading room, and you'll be presented with these papyrus scrolls that are placed between two plates of glass, and in those scrolls are 108 descriptions of dreams and what their interpretations are, what their prophetic interpretations are. So that's the oldest description that I'm aware of surrounding anything to do with sleep, but I'm sure that there are many other examples out there.
Fascinating. I mean, there is this rumor, and I'm not sure how valid it is, that we're not always sleeping like the way we do nowadays. So the rumor has it that before the Industrial Revolution, people would sleep in 2 shifts and would sleep, let's say, more tight. The sleep would be more tightly linked with sunset and sunrise. So people would go to bed after sunset, sleep for a few hours, wake up to do some house chores, visit friends. I mean, that sounds really weird. You're knocking on someone's door at 1 a.m. for a chat. And then they would sleep again until the sunrise. But when the lamp was introduced, at least this is what the rumor says, well, everything changed. And especially nowadays that we're surrounded by artificial light. So my question is, are we forcing ourselves to sleeplessness until, we get tired enough?
Yeah, I think this is quite a controversial theory in that this concept of segmented sleep has been put forward by a historian who's found multiple references to first sleep and second sleep in historical texts. But first of all, on a biological perspective, this does not necessarily make sense unless you've got a very long dark period. And of course, the further you are from the equator, the less dark time there is in the summer, and so that you would have insufficient sleep if you're following those rules. If you take individuals into a situation, so for example, like Nathaniel Kleitman, who was one of the earliest researchers in sleep medicine, who took his students down into Mammoth Cave system in Kentucky, which is one of the deepest cave systems in the world, and he didn't demonstrate this segmented sleep in those contexts. And if you study sleep in pre-industrial societies, or at least societies that have not had access to electricity or any other sort of modern life in sub-Saharan Africa or in the Amazonian rainforest, they don't necessarily exhibit these patterns of segmented sleep. So there are some people who would strongly contest this view and say that it's really just a description of insomnia, essentially.
Wow.
That people are having, you know, sleep maintenance insomnia. So I think it's an unresolved area.
So relevant to my previous question, and the way our stressful lifestyles are certainly adversely impacting on our health. There is this fresh paper in JAMA Neurology by Eileen Leary. So I'm going to keep it short and sweet, though there's nothing sweet about what I'm going to say. So they found that lower amounts of REM sleep were associated with increased risk of all-cause mortality. And actually, there was a 13% higher mortality rate over 12.1 years for every 5% reduction in REM sleep, meaning you sleep less, you live less. Is that right?
Well, I think they didn't really make any judgment about the causality, and that's a really important issue.
Yes.
In that we know that the proportion of REM sleep that we exhibit as we get older gets less and less. And therefore, could this simply be a marker of aging, of biological aging, not necessarily chronological aging? And so we're a long way away from saying, well, actually, if you reduce your REM sleep, you're at increased risk of mortality. I mean, by and large, if one looks at mortality curves for sleep duration in general rather than REM, we see that it is largely U-shaped. So if you sleep less than 6 hours a night, your mortality risk goes up. If you're sleeping more than 9 hours a night, your mortality risk also goes up. Now, there remains ongoing debate about whether or not this is, at least the longest sleep duration is as a result of confounders or not. But certainly, short sleep seems to be conducive to short life, is what the data is telling us.
And although you've already hinted a bit, in that in your answer. So, what is the right amount of sleep?
So if one looks at the right amount of sleep for an adult population, it is somewhere in the region of between 7 and 8.5 hours sleep. But we know that there are individuals who sit outside of these parameters, in that our sleep duration is to some extent influenced by our genes. We have a long sleep requirement or a short sleep requirement, and so you may well sit outside of those margins and still be normal. And so the answer that I usually give is the amount of sleep that is the right amount for sleep for you is the amount of sleep that enables you to go to bed and wake up at the same time, to feel refreshed during the day, and then to be ready for bed the following night. It's a bit of a cop out.
I see. I think that I need more sleep, doctor. So now we may have our eyes wide shut, but our brain has a party up there. So can you give us a brief overview of what's going on in our heads when we're falling asleep?
So we divide sleep into two major categories of sleep. There is non-REM sleep, and during this stage of sleep, if we're looking at the electrical activity of the brain, the EEG, the brainwave slow, there are some other EEG patterns that come out that really define the substages of non-REM sleep. And then there is this other stage of sleep called REM sleep, which we've historically always referred to as dreaming sleep. It's certainly the stage of sleep that we most associate with dreams, particularly these dreams of a narrative structure. And during REM sleep, that's a very different physiological and electrical state from non-REM sleep, because if we look at the EEG actually looks surprisingly similar to the EEG of wakefulness. But the body is in a very different state. We generally have muscle atonia, so all our muscles lose their tone. The only muscles that maintain their tone are the muscles that move our eyes from left to right, hence the term rapid eye movement sleep, and the muscles that allow us to breathe. So essentially, we are very alert internally, but externally, we are completely dissociated from the outside world.
And since you mentioned the dreams, so What is the dream factory in the brain?
Well, I think that's a really complex question with a complex answer. And what we know is that some of the areas in REM sleep during this stage of sleep during which we have these dreams of narrative structure is that the visual parts of the brain, so the occipital lobe, seem to be more active. The limbic and paralimbic structures are more active, and areas like, for example, the frontoparietal association areas seem to be reduced in activity. But this, essentially this is a widespread network effect rather than simply due to one anatomical location.
I mean, now, Freud famously said that dreams are the royal road to unconscious, and analyzing the content may be useful for the, psychotherapeutic process. But what do dreams mean to a neurologist like yourself?
Well, I think the big interest in dreams from a neurological perspective are that we understand that alterations in dreaming mentation are associated with particular disorders. The area that is most of interest to us as neurologists is in individuals who act out their dreams. So I mentioned the fact that in REM sleep, normally we're completely paralyzed, but in some individuals, that mechanism of paralysis that's associated with the REM sleep doesn't work properly and people act out their dreams. Historically, we always thought that that was an idiopathic condition, idiopathic REM sleep behavior disorder. But of course, over the last 10 or 20 years, we've now begun to appreciate that that is actually a precursor state for alpha-synucleinopathies, so neurodegenerative conditions like Parkinson's disease or dementia with Lewy bodies, or multiple system atrophy. And this is of great importance because when we're talking about disease-modifying drugs, we don't have any at the moment, but certainly when we do have those drugs, who are you going to want to start those drugs in? Ideally, individuals who are in the very early stages, perhaps before even any outward manifestations of those neurodegenerative disorders exist. And patients with REM sleep disorder may well be the absolute go-to cohort of individuals to trial these medications in. There are other changes with dreaming sleep, for example, in narcolepsy. So patients with narcolepsy will often experience very vivid dreams overnight and will often sometimes experience lucid dreaming overnight as well. About 80% of people with narcolepsy describe lucid dreaming.
I mean, in a really beautiful recent paper by Francesca Ciclari in Lateral Neurology, she talks about dreams and nightmares in healthy adults and patients with sleep and neurological disorders. So at some point, the authors talk about people that have been paraplegic since birth, that they actually walked in their dreams, and suggest that there is a cerebral walking program which possibly develops via mirror neurons. So they're activated when observing others perform an action. And that these neurons and this program is reactivated during sleep. While actually another study showed that dreaming of doing movements principally elicits activation in regions involved in the perception of the motion itself. So how do you think we can use this information in our clinical practice?
Well, I think that your REM sleep has long been held by some individuals as having one of its basic functions being about motor rehearsals. And that goes back to Juvet in the 1950s and 60s, who would lesion the brainstems of cats in order to essentially produce REM sleep behavior disorder. And he noted that the behaviors that they were exhibiting were largely to do with fighting or chasing or running away from something. And so he argued that actually one of the functions of REM sleep is the rehearsal of motor behaviors that are important for survival. And this idea has very much continued. Now, one of the difficulties with manipulating dreaming is you need to be a lucid dreamer. So you need to be able to have some conscious awareness of the fact that you're dreaming at the time that you're dreaming, and to some extent have control over the content of your dreaming. Now, that sounds somewhat bizarre, but actually lucid dreaming is a well-described phenomenon that has an underlying neurobiological basis. And this has created a lot of interest from sleep and dream researchers. But in theory, if you are able to lucid dream and you could rehearse certain behaviors, then that might have implications for people with traumatic brain injury, for functional neurological disorders.
Yes.
One of the great areas of interest is in the use of lucid dreaming for treatment of PTSD associated nightmares, because if you have some control over your REM sleep, over your dream mentation, then actually you can fundamentally control the content of your nightmares and alter the outcome. So there are lots of potential avenues. These are in very early stages of development at the moment.
I mean, I'm really happy that you mentioned that, because, you know, I found this paper by Anna Castelnuovo in Nature Reviews Neurology. And so her team focusing on the non-REM parasomnias. So for people not familiar with the term, these include sleepwalking, sleep terrors, confusional arousals, among others. So describing what happens in the brain during the non-REM parasomnias, they state that essentially one part of the brain is awake. So the motor cortex, the limbic cortex, and the amygdala, they are essentially in a awake state, while another part of the brain, and the part especially responsible for consciousness and memory, it remains in a sleep state. So now that suggests that consciousness and self-awareness switches off in a way, which obviously brings us also to the beautiful realm of the forensic sleep medicine. So then there is, the other theorist, Carl Friston, talking about, that in fact consciousness doesn't cease to exist during sleep. So what is the truth? So are we conscious or are we not conscious?
Well, I think that one of the mistakes that we make when we look at sleep is that we divide it into different stages. And it's not, I think sleep is a continuum. The sleep stages are a continuum. Not only that, but as you describe, sleep is not even a global brain state. It's a focal brain state, and different parts of the brain can exist in different stages of sleep or wake at the same time. And that is illustrated by the non-REM parasomnias, as you describe. It's illustrated by a lot of the conditions that we see in the sleep clinic, like hypnagogic hallucinations or sleep paralysis. It's the blurring of these boundaries between different brain states and in different parts of the brain. In fact, that we know that even during full wakefulness, or at least we think, we don't know, but certainly experimental evidence points to the fact that actually when we're in full wakefulness, there are small areas of the brain constantly dipping out in and out of local sleep. And so this is an absolute continuum. If you're a lucid dreamer, then you have awareness in dreaming sleep. If you're a non-REM parasomnia sufferer, then you may have some retained awareness during some of the non-REM parasomnia attacks. But my view from a forensic medicine perspective is that during those incidents, essentially our brains are lesioned. They may not be lesioned by a traumatic brain injury or by a stroke, but they have a transient functional or neurophysiological lesion because they are not working in the way that they normally would do. And if you have transient disconnection, for example, for want of a better phrase, disconnection of the frontal lobes whilst you're walking around your room in the middle of the night because your frontal lobes remain in very deep slow wave sleep, then one can be the forensic implications are the same as somebody who, for example, is in a diabetic coma or has just had a seizure and is in a postictal state.
Amazing. I read, let's say different case reports that you published back in 2015. So a gentleman came to your clinic as his partner noticed that he was sleep talking. And when I say sleep talking, she was talking about his ex-girlfriends, describing explicit sexual activities with them. And as a result, obviously his partner went furious, and he has been forced to spend many nights at a local hotel. Now the guy, the patient himself, so he secretly recorded himself a few nights. And not only was he not sleep talking, but it was his partner that was screaming and shouting at him. Basically, it was a lie, and his partner was using these accusations to get more money from him, like an extortion type of thing. So how often do people lie or exaggerate about their sleep problems?
Yeah, so I have a bit of an admission to make about that case report. So we originally wrote that case report up as a case of gaslighting because his partner had been reviewed by a psychiatrist and had been given a clean bill of health. But actually, you know, I wrote about that case in the recent book that I published with a bit of an update, in that it became clear that in the years afterwards, that actually the partner was exhibiting behaviors that suggested that she was suffering from mental illness, from some sort of psychotic illness. And so what was originally written up as gaslighting probably, I think, reflected his now ex-partner's, obviously, psychopathology. How often do patients lie? Well, I think there's two ways to answer that question. The first thing is, how often do they frankly lie? It's very, very unusual. So I think one of the other cases that I write about in my book is the case of an individual who essentially was malingering by simulating idiopathic hypersomnia, so profound sleepiness, after the birth of his child. And for about 5 years would regularly spend 18 to 20 hours a day in bed, unable to interact with his child and with his wife and help looking after the child. And actually it was 4 days before he was due to be admitted into the Leschziner unit that he suddenly recovered and was cured of his idiopathic hypersomnia. But those are real exceptions. One thing that is really important to say is that we're very, very poor witnesses to our own sleep. So there is often a very big disconnect between subjective experiences of sleep and objective experiences of sleep. Now, some of that is simply because of some of the psychological features surrounding sleep. Some of that is probably because the techniques that we have to record sleep give us a very limited view. So, for example, people who have paradoxical insomnia who say, I didn't sleep at all, but actually you record 8 or 9 hours sleep when they come into the sleep lab, actually probably exhibit some waking-like behavior in certain parts of their brain that we can pick up using high-density EEG, for example. So it's a limitation of the technology that we use to record sleep.
I mean, you know, back in 1996, so Breslau did a classic now epidemiological study of young adults linking, you know, sleep disturbance with psychiatric disorders. And this year, in fact, Nicholas Mayer published a meta-analysis on sleep and circadian rhythm disturbance in schizophrenia and bipolar disorder. Now, one of the implications they mentioned is that, in fact, actigraphy, which is a way of measuring, you know, rest and activity cycles, it serves not only as a trade marker for quantifying, you know, the stability of the remission and the risk of the, you know, adverse outcomes, but also as a state marker for predicting changes in someone's mental state, including relapse. But until we reach that point, though, that we can use actigraphy to accurately predict when someone is going to relapse, what are some practical tips from a fellow neurologist to a psychiatrist?
Well, I think there is increasing interest in, for example, using as this sort of technology, because essentially smartphones have a similar sort of technology to actigraphy. They have 3-axis accelerometers, and actually you can capture an awful lot of data on smartphones. I guess that what the data suggests is that there are two things that tend to be a marker. One is worsening sleep, poorer quality sleep. And the second is an alteration in the circadian rhythm, as you said. So using things like consumables, consumer-based sleep trackers is not a ridiculous thing to do. Now, we have major concerns about the use of these fitness trackers to diagnose, but actually what you're looking is, if you're looking for trends within an individual. And so if an individual is noting that there is a change from the long-term baseline in terms of their fitness tracker, then that may be a very important use, an indication that actually they're at risk of deterioration.
So let's say then a bit more clinical. So what is the minimum that you would expect from a sleep history?
Well, I think the average sleep history, and I'm not necessarily saying this about psychiatrists, but the average sleep history amongst neurologists as well as psychiatrists and other specialties is, how's your sleep? And they write good, bad, or awful in the record, and that's it. So I think the key thing to try and understand, you know, it's very difficult for me to go through an entire sleep history in a podcast. But essentially what you're trying to understand whether or not this patient has insomnia, in which case, do they spend time in bed when they are tired and want to sleep, but they are unable to do so? Are they chronically sleep deprived? So is it the case that when they are in bed, they sleep very easily, but still remain tired, and when given the opportunity to sleep more, they will sleep more? Or do they have a sleep disorder, which is, are they sleeping more than 8 to 8.5 hours and still feeling tired and unrefreshed? And really just distinguishing those three things is a very good place to start.
Amazing, thank you. And what is the most common mistake you see from medical colleagues when prescribing for sleep?
Well, I think generally speaking, it's jumping to hypnotics very early for insomnia. We now know that treatments like cognitive behavioral therapy for insomnia are non-inferior to hypnotics in the medium to long term, and perhaps more effective in the long term. The other thing is not appreciating that actually the drugs that you're prescribing for something else may be having a big impact on sleep. And so in psychiatric terms, things like mirtazapine in particular, but antidepressant drugs in general, causing significant restless leg syndrome, or the SSRIs or the SNRIs causing sleep disruption directly. So things like that.
It seems that that we've been stuck with playing around with GABA, histamine, and melatonin in the brain when trying to help people sleep. But it seems there is a new kid in town. So there have been 2 recent randomized controlled trials praising, and I don't know how much praise they deserve, the orexin antagonists for the treatment of insomnia. So are we going to see them in the UK anytime soon?
Well, I think these are licensed in the US, and they are being used in the US. They, as far as I'm aware, are not being used anywhere in Europe at the moment. I don't have any clinical experience of these drugs for obvious reasons, but the feedback from my colleagues in the States is that these are perhaps no more effective than the drugs that we have available, and it's yet to be determined whether or not they have problems in terms of habituation and the other problems that are associated with benzodiazepines and Z drugs.
That's disappointing. So Martin Luther King once said, "I have a dream." So what's your dream, Guy?
Well, my dream is that all this data that is being churned out by various centers around the world, which shows constant conflicting data regarding associations between sleep measures and health outcomes, becomes a bit clearer. And I think the only way that it's going to become clearer is if we have cheap, widespread technology that can accurately record sleep in the long term rather than the short term. At the moment, we only have a PSG where we can record individuals for 1 or 2 nights, or we have things like actigraphy or your Fitbits, which only record movement and don't really record sleep. So once we're able to record sleep in the long term for months, even years, in very, very large numbers of individuals, then I think some of these associations are going to become clearer.
Thank you so much, Guy. BRAINCAST people, if you haven't already, head to your local bookshop and grab a copy of his books. Guy, which one should they buy? The Nocturnal Brain or the Magic Word of Sleep? Which one?
They are the same book, but one is hardcover, and
why do they get with a different title?
I have no idea. This is a source of great irritation to me.
And before you ask your manager for protected sleep time during the day, make sure you pack your hiking boots and a sturdy tent, because next week we're flying deep into the rainforest of the Peruvian Amazon to see how locals have been using ayahuasca and what we can learn from them. Okay, we're not going anywhere, but my guest did, and he will tell us all about it next Monday with Dr. Simon Raphael. And on that note, Pospo and BRAINCAST for Monster Learning, over and out.